Myotome is defined as a group of muscle supplied by a single nerve root, and the procedure for testing myotomes is very similar to the MMT, both in its testing procedure as well as its scoring. But myotome tests are specifically used to try to determine if specific nerve roots are responsible for weakness, and are often used if a patient's sign or symptoms are kind of suggesting nerve root pathology. As for which spinal level is evaluated at each test, we have C3 being cervical lateral flexion, C4 shoulder elevation, C5 shoulder abduction, C6 elbow flexion and wrist extension, C7 is the flip, elbow extension and wrist flexion, C8 thumb extension and finger flexion, T1 finger abduction and adduction, T2 to L1, there are no myotome tests present or that we know of. For L2, that's hip flexion, L3, knee extension, L4, ankle dorsiflexion and ankle inversion, L5, great toe extension, S1, hip extension, ankle plantar flexion and ankle inversion, and for S2, that is knee flexion and ankle plantar flexion. For deep tendon reflexes, the general procedure is to have your patient in a relaxed state with a tendon that's going to be tested on a slight stretch. Then you'll briskly tap the appropriate muscle in the appropriate location, or the appropriate tendon in the appropriate location using a reflex hammer. And the force of the tap should either cause a hypo or hyper reflexive response. As for which spinal level is evaluated at each location, C5 will be tested on the distal biceps tendon, and the response we're looking for is elbow flexion. C6 is going to be on the proximal, like 1 to 2 inch proximal to the radial styloid process, and you're also looking for elbow flexion and possibly pronation or supination. For C7, this will be on the triceps just proximal to the olecranon process, and you're looking for elbow extension. For L4, it's going to be near the patella, and you're looking for knee flexion, and you'd want the patient like seated. And then for S1, this is testing the Achilles, and the response we're looking for is ankle plantar flexion. As previously mentioned, when doing the deep tendon reflexes, you're either going to get a hyper or hypotonic response or reflex. If you have a hypertonic response, which is more than you would expect and kind of having a spasticity, that's an indication that it's an upper motor neuron lesion. And as for lower motor neuron lesions, we get more of that hypotonic, which is a response that's less than we would expect. As for upper motor neuron tests, which again is going to provide that hyper or overreactive spastic response, there are 3 tests, which are the Clonus, Babinski, and Hoffman's test, which we've kind of looked into this week. For the Clonus test, you want your patient in a supine position with their knee slightly flexed while supporting their limb, and you're going to passively move their foot from plantar to dorsiflexion several times, increasing the speed until you rapidly dorsiflex the ankle and hold. If it is a positive Clonus test, you'll feel that spasticity or oscillations back and forth, and that's an indication, yes, that it's positive for the Clonus test. The Babinski test is otherwise known as the plantar reflex test. So for this test, you're going to use an object with like a distinct but not necessarily sharp edge. A lot of people like using the back end of a reflex hammer, and you're going to stroke the bottom of the patient's foot from medial to lateral, kind of arching just beneath or proximal to the toes or digits. And if the toes extend, that is a positive Babinski test. Lastly, for the Hoffman's test, you're going to grasp the distal phalanx of the patient's middle finger. Should probably demonstrate with my better finger. The middle finger between your thumb and index finger, and you're going to put pressure over the distal phalanx or fingernail by kind of inducing a flicking motion over their finger. And if the patient's thumb and other fingers flex, this is considered a positive test. You would do upper motor neuron testing on patients who you suspect might have brain or spinal cord injuries, as well as diseases that could possibly affect the upper motor neurons. And specifically, it's typically conditions of the nervous system. And the goal in this is to try to identify where the CNS lesion is in order to provide interventions and hopefully like the best patient outcomes. Some of the most common conditions of CNS are things such as stroke, a spinal cord injury, multiple sclerosis, and when doing these tests on patients with these conditions, you'll kind of see the most typical presentation or like textbook signs. However, atypical presentations are not uncommon.